Good day, I'm Dr. Abdulrahman. Today I will illustrate our topic regarding compliance of endoscopic retrograde cholangiopancreatography according to the current American Society of Gastrointestinal Endoscopy and adverse outcome in a patient with specific. First of all, authors have no conflict of interest and there is nothing to disclose. There is no relevant financial, either non-financial involved in this studies. We'll go through the background, the method, and the result discussion, and lead by conclusion. The prevalence of choledocholithiasis is estimated by 1 to 15 patients who has cholelithiasis, and has been from 4 to 18% of patients underwent cholecystectomy. There is two imaging modalities considered for confirmed diagnostic with the presence of combined stone or choledocholithiasis. A non-invasive, which is called magnetic resonance cholangiopancreatography, or endoscopic retrograde cholangiopancreatography, which is considered as invasive diagnostic and therapeutic modalities. And many studies shows it has superior compared to the other non-invasive modalities with a high sensitivity and specificity. On the other hand, Andrelli conducted studies which shows a high morbidity rate and complication among the patients who underwent ERCP by 6.9 with a calculated death rate 0.3. According to the American Society of Gastrointestinal Endoscopy, they divide the patient into four categories, but we divide into three categories: the high and the intermediate and the low likelihood. The high likelihood, the very strong and the strong, they will go direct for ERCP. The intermediate, they will go for MRCP, and if suggested, they will go for ERCP. The low likelihood will go directly for endoscopic retrograde cholangiopancreatography, will go directly for cholecystectomy. Sorry. Our objective to measure the compliance of the AGES guideline for symptomatic cholelithiasis who suspected to have choledocholithiasis and its outcome, and to determine the adverse outcome of ERCP at King Abdulaziz Medical City. Our studies was retrospective cohort studies. The ethical approval was obtained from King Abdullah International Medical Research Center. The inclusion criteria were any patient above 16 years old admitted from January 2017 until January 2019. With the exclusion criteria, any patient with a pancreatic duct stone or pylori anomaly or pylori cancer. And for the patient characteristic, we enrolled both gender with variable including common bile duct dilatation, a presence of common bile duct stone or sludge on ultrasound, level of bilirubin and the level of alkaline phosphatase, and the level of liver function test, AST and the ALT and the gamma glutamate, and the clinical evidence of cholangitis and the pancreatitis. All these characteristics was recorded a day before the procedure performed. We conducted all the characteristics by helping of Google form, and we conducted into the Excel sheet by using SPSS for analysis. We consider a p-value significant when it's become below 0.05. This is table. Before I will go illustrate our tables, our population were 800 to 826. Among them, more than 50% were compliant to the guideline. The accomplished among the high likelihood, which had the majority, and the low likelihood. Most of them were compliant to the guideline. Among the high likelihood, more than 70% were compliant to the guideline. Among the low likelihood, more than 90% were compliant to the guideline. On the other hand, among the intermediate likelihood, more than 80% were non-compliant to the guideline. And in this table, we illustrate the presence of ERCP stone by the compliance with AGES guideline. Among the high likelihood, actually there is a significant association between the positive stone or sludge among the compliance patients with 0.04. And among the intermediate likelihood, a patient who underwent ERCP were around 50. Around 45 of patients of intermediate likelihood were underwent ERCP, either compliance or non-compliance. Some of them were underwent ERCP and were non-compliance and found to have a negative stone, were found to have a positive stone, as shown here. Like more than 50% of patients who underwent, of intermediate likelihood, who underwent incompliant ERCP were found to have a positive stone. And this table illustrates the presence of MRCP stone and sludge by compliance to the guideline. High likelihood patients should not underwent MRCP, although more than 50% of high likelihood who underwent MRCP, they have found to have a negative MRCP stone. And among the high likelihood, more than 90% of a patient who underwent intermediate likelihood were found to have a negative stone. And this table illustrates the adverse outcome of ERCP by compliance to the guideline. As shown, there is a significant association between no adverse outcome and the compliance to the guideline, to the AIDS guideline. And discussion, the majority of the non-compliant, as shown, will illustrate among the intermediate likelihood, reaching up 83%. In the high likelihood, I will say the majority of them underwent ERCP. 76 were found to have positive stone, while 23 were found to have a negative stone. This go with the studies what conducted by COSO. For the high likelihood, more than 79% were found to have a positive stone. Moreover, the majority of patients who underwent MRCP were found to have a negative stone, and also this goes with studies showed 89 patients who underwent MRCP, and of them, more than 70% were found to have a negative result. Based on our finding, more than half of the patients of high likelihood who were non-compliant to the guideline and underwent MRCP were found to have a negative MRCP stone and scheduled for laparoscopic cholecystectomy. In contrast, 23% of high likelihood had a negative result, adding the risk of unnecessary intervention and increased the hospital length. The result showed 80% of all patients, as say there is significant association between the compliance to the guideline and no adverse outcome. So, in our conclusion, the classification of intermediate likelihood as knowing the most of the people did not receive a compliant guideline. We believe it's because the wide scope of prediction of the intermediate group, physicians believe that not following the guideline would be result better outcome than the following the guideline. We believe that due to the wide range of variables to determine the likelihood for each patient, we suggest more specific predictor among these intermediate likelihood to narrow the predictor more for further management. This is our bibliograph and reference, and thank you for listening. I'm Dr. Abdulrahman, and thank you.